patient is 41-year-old male with 20 mm pancreatic tail tumor with mixed solid and cystic features on CT and MRI. EUS FNA will be performed by Professor Wang.
Hello.
Hi,
Hi.
we can hear you.
Welcome to this room, and I have Professor Ryozawa and Fukami. Sorry. To comment for my procedure. This case is 41 years old male, and he had instantly finding of pancreatic tumor. According to the CT scan, is enhanced tumor with central non-enhanced part. So for the enhanced tumor, according to the CT scan, before we perform the US, maybe we will consider is neuron-acquired tumor with CT change. Or maybe serous cystic adenoma is also hypervascular tumor. And besides some metastatic tumor like renal cell carcinoma, there also is hypervascular. But this case, no evidence of a renal tumor. So today we want to find the tumor and the characterize the tumor. And if it's a hypervascular, I want to use a contrast enhance to prove it's a hypervascular tumor. And for the young people have a neuroendocrine tumor, I have to look for the second or third small nodule because there are possibility of MEN1 syndrome. So I will start my procedure. And lastly, we will discuss about the puncture or not puncture. Okay. So my procedure usually perform from lower esophagus. I want to check the liver for a while. This is a portal and CBD, portal CBD, and hepatic artery. This is a liver. This right side here, and I will turn to the left side. This patient have a very small, unusual anatomy of left lobe of liver. However, we didn't see any solid tumor in this part. So I will. This is portal vein and CBD. Maybe there are some lymph node between the portal vein and the CBD here. But it's longitudinal, and they also have a central hyperecho. I think it's a benign region. Are you agreeing? Yes. Yeah. So after survey the liver, I will go to the pancreas. Yeah, usually I sometimes young doctor will confuse cockroach counter cockroach. So, however, if you can see the kidney is to the tail, this is pancreas, and they are very apparently basal. This one is artery, one is splenic artery, one is splenic vein. 10 minutes? Okay. So we will go to the tumor. It's very end of the pancreas. According to the CT scan, his pancreas is down, not upward. So can you see the tumor here? Yeah, it's a cystic tumor with hypoechoic and well defined. Here. Yeah. And the size is around 2 centimeters. So now we have to characterize the tumor, and my procedure is I will enlarge the index target region, and I prefer use the tissue harmonic, especially tissue harmonic penetrating. We can see more and more clear for this case. And for this case is a solid part and also cystic region maybe there are some cascade here. I will show. Here, there are some cascade. So for neuroendocrine tumor and also cirrhosis adenoma, there will be a cascade. But for this case, we didn't see maybe a small cyst, maybe more solid. So now for this lesion, I will use the contrast enhance. But before the contrast enhance, is there any question from the audience? If no, I will use today we use ME2 system, Olympus. So there, the keyboard, you have to use contrast enhanced mode. And we will especially emphasize the medical index. This usually use sonazole. We will in 0.18 to 0.22 or 2.5. And in this situation, we can compare the tumor, and you can see the the tumor in the routine ultrasound is here, and this area is the target. So after the contrast, we will see this part is enhanced or not enhanced. And we can control, if you're using the background is too bright, you can use some contrast to decrease. If you're using is too dark, somebody use a high index like this. You can, 5 minutes? Okay, like this, as you like. And in this situation, the medical index is 0.35. And it can make the bubble destroy. Okay, let's go. The patient is 85 kilometers, so we use 1 cc. Yeah.
Dr. Wang,
Yeah.
what type of enhancing pattern would you expect for neuroendocrine?
I think it's homogeneous enhance for neuroendocrine tumor. Yeah.
And if it's a cirrhosis adenoma, do you see the different enhancing pattern?
Yeah, he's maybe even show the cystic component more clear. Yeah. Is that now? Oh, so
Yeah,
it's
it's injected
you have to time
already.
in. Okay. You should.
Sorry. They have injected already.
Yeah, okay. Usually, you will enhance around 20. Oh, no. They have. Yeah. So this maybe 10 second pass. So now it's 11. No, not 11. 20. Now it's 20. For this case, there are not so many perfusion. So maybe he is not neuroendocrine tumor. Only a little perfusion, but mostly it's not. No enhance.
So
it's,
you mean it doesn't look like neuroendocrine?
Yes. We have experience. After the puncture, actually is other kind of a malignant. So for this case, it's not. Now, usually we observe 2 minutes.
Professor Wang,
Yes,
this is Ichiro.
yes.
I feel the lesion looks like epidermoid cyst because the
Epidermoid.
echo texture is
Epidermoid
similar to spleen
Yeah.
and not so hypervascular, and the margin is not so clear as a neuroendocrine tumor.
Epidermoid.
The solid part of the lesion is very similar to spleen.
You mean the spleen?
How do you feel?
You mean this is spleen?
Ectopic spleen.
Ectopic spleen,
Yes.
my experience is also enhanced. Yeah, it's also enhanced region.
Yes, please
But for-
compare the vascularity to
This
with
one?
the spleen.
Yeah, a spleen. You can see the spleen is more
Yes,
bright
yes.
compared with before.
Okay.
Okay, let me see. This is a spleen here, so it's not so enhanced, huh? But it's a spleen is here. I think it's enhanced because the contrast enhance harmonica. Sometimes very far distance is not cannot be checked, but you can see here. We can see the flow, because now it's over 2 minutes. Maybe it's not so bright. So this case, I think maybe it's not neuroquine tumor.
So EUS FNA is needed for this case?
This patient, I think he had to go to operation. So
directly?
yeah. So no need FNA for this case. I think so. So the conclusion is hypo contrast tumor. Yeah. So operation is needed. Is there any question?
Ichiro, how do you think about, for this case, EUS FNA is needed or not needed?
Sorry. I recommend FNA.
Yeah.
You should perform FNA.
Already.
If it was
Why?
epidermoid cyst, don't need surgery.
Okay. Okay. I perform.
Yeah.
But do I have
I
time?
think it's best to confirm the need for surgery. I agree.
Okay.
I mean, what's the sensitivity of contrast enhanced study to pick up the neuroendocrine tumor?
I think it's maybe it's over 80.
Over 80%?
Yeah, I think so. It's very typical. So once we have question is if the contrast enhanced lesion is a neuroendocrine tumor, do we need to perform FNA or not? That's one issue. But of course, conclusion is we still have to FNA. Okay, I perform the FNA.
Okay.
Do I have time?
Which size? Which size do you need? 22 or 19?
22.
22, okay.
So my point was,
no.
if
Give me
the contrast
19.
enhanced study
19.
Yeah.
is sensitive enough, you can exclude a neuroendocrine tumor. That's good. But if there's a small chance that we are missing the
Yeah.
possible diagnosis,
Yeah, yeah.
I mean, more than 1 centimeter neuroendocrine tumor is concerning. More than 2 centimeter, it's going to be a surgical indication for sure. So, if we confirm this is a neuroendocrine tumor, I agree that patient should undergo surgery.
Yes. Okay. We have performed the first FNA, use a 19 gauge, because if we would think is a little possibility of neuroendocrine tumor, we want to have a grading of the neuroendocrine tumor. So we need a larger specimen. Now I change it to 22 gauge because just now, when you puncture, there are some blood after suction. So I use 22 gauge.
And how many passes are you planning to do?
If we use the, because in my hospital we have on-site cytology, so we can puncture until we get the answer.
Okay.
But averagely, I puncture 3 or to 4.
Okay. Thank you.
But if I use the 19 gauge, I maybe 2 to 3.
How about the suction? You always use suction?
No, it's a hypervascular. I don't. Just because just now the contrast is not so enhanced, so I just want to suction. So this puncture I will. Sorry. Can you keep the scope for me?
Yes.
Yeah, okay, please. Uh-oh, go out. So this is a very tail portion of the tumor, so it's not easy to keep the scope. Okay. Now I go inside. This time I will not suction.
No.
Please, yeah, no need. No, move the. Yes, yes. Because just now the blood. Today I use a EG Sharp 3 and with a side hole. So I hope to can get more tissue. And because the EG3 is wear angle is only 16, very good to puncture. Okay. Okay.
Dr. Wang,
Yes.
which needle are you using?
EG Sharp 3
Okay. Thank you.
with a side hole, because the EG Sharp 3 can with side hole or no side hole. So because I want to get more tissue, so I use a side hole.
So Dr. Wang, have you seen consistently more tissue with the side hole?
My experience, Poco acquire and 19 gauge of EG Sharp 3 can get very good tissue. So for the sometimes if I didn't Proco or acquire are not available, I will choose the 19 gauge EG Sharp 3 with side hole.
How about the Boston's new needle,
In
Acquire?
the Aqua is not bad, but when puncture there are some resistance because the design. And the Proco 20 is also very good. Yeah, but the puncture ability, I think EG Sharp 3 is better because the angle of the EG Sharp 3 is very good. And maybe Medigrove also very good because he's 15 degree, and the EG Sharp 3 is 16. And the expect Boston is 25. Yeah. So should we perform?
I think cytology is almost ready.
Not so many specimens.
Oh, okay. So we have seconds. So should we puncture, sir?
What do you think about shark core needle?
Shock? Shock,
Core.
I have no experience of shock. You mean the Medtronic?
Yes.
Yeah, I have no experience.
Well, Shako, in my experience, is really, really good for obtaining core specimen. And there should be a good comparison study to be planned. But all this biopsy needle has very good sample ability to get the core tissue. I really like the shock core.
Dr. Wang?
Yeah, hello.
I got-
Yes, the pathology, cytology result
Yes.
maybe come
I've
out.
got-
Yeah,
got-
I will let the pathology to explanation for us,
Okay.
please.
Okay, I got the report from the pathologist, and I will read that. There are many small and round-like cells, and these cells are forming rosette like lesion. And these findings are compatible with neuroendocrine tumor. So that was the result of cytology.
Okay. For this case, under the US, maybe there are some discrepancy between the contrast enhanced US. But just now I discussed, we have review. Maybe I apologize, the contrast and not totally injection into the blood. Maybe we have to flush. That's how we ignore this procedure. Maybe this case, as shown on the high flow Doppler, is show the hypervascular tumor. That's just because the contrast is not into the blood, so just partially into. So we cannot show very good picture of the neuroendocrine tumor for everybody. So we also hope this tissue, no matter have a grading or not, the patient maybe need operation. Is my opinion. Thank you.
Okay, and can we have some comments from Dr. Hukami and Dr. Ryozawa?
So the path number 2 with the 22 gauge with minimum suction actually yielded the diagnostic slide. So if there's a potentially a neuroendocrine tumor, reducing suction would be helpful to reduce the contamination of the blood. But again, this is the case that the clinical suspicion and endoscopic findings, you have to put them together in the context and find out whether you should move forward with the sampling or not. So I think sampling was the right thing to do, and modifying method of sampling made it successful outcome.
Okay, on EUS FNA, as this case, at first, Professor Wang used the suction, 20 millimeter section, and the blood coming, and then changed to no use to suction. So there is no only method, but depend on the situation and choose the method.
Okay.
Okay, thank you, doctors. We'll go back to Dr. Hagi's room.
Thank you.
Thank you for your